Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the NAIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on first and third Friday of every month from 3 p.m. onwards. The NAMS-AIIMS PGIMER CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medico CME is to help them to be more proficient in their profession. Each session will cover one or two topics followed by questions and answers. Thank you for your kind support.
काट रही है
Hello and good afternoon, everyone. To the next program, next CME program by National Academy of Medical Sciences. Since we all know that NAMS has been conducting various Navigate CME programs in coordination with AIIMS and PGIMER, and the current series on dental and oral health is very interesting. And since beginning, this is being coordinated. This is the chief coordinator is none other than Professor O.P. Kharbanda sir. So in the entire series, since the participant who has been consistent, they might have observed particular emphasis on two things. One is teleconsultation, since in India we have lack of resources, mainly in terms of the medical and dental health. And the second one is again AI and its role in early diagnosis. So today, again, to cover this topic, with us we have Dr. Deepika Mishra ma'am. So currently in today's era, if we see, everyone is talking about AI algorithm, about mobile clinics and use of AI in diagnosing things, in having rapid triages, just to make an earlier detection and earlier intervention, definitely. So again, without wasting much time, I would like to request Professor Umesh Kapil sir. Sir is the Secretary of National Academy of Medical Sciences for the welcome address. Over to you, sir.
Good afternoon to all the respected participants and Professor Kharbanda sir, Dr. Deepika Mishra. We are most grateful to you for sparing your valuable time for Navigate program, which is being organized by National Academy of Medical Sciences. This is essentially to improve the competency and knowledge of the postgraduates and the young faculty members in different topics which are relevant to common to all the specialties. Now, if we look at the current scenario of the country, we have almost 1,20,000 MBBS students who come out of it. who pass the exam. And out of 1,20,000, there's a hardly 20,000 seats which are available for the post-graduation. So what happens to 100,000? They again prepare themselves. So the national virtual postgraduate CME program is to improve their knowledge and try to update them so that they can appear for the NEET examination and qualify for their postgraduate entrance. Now, another important thing is that we are maintaining a virtual library. All these presentation, they are on the NAMS library, NAMS website. All the presentations are live on the YouTube, so that those who have missed, they can also visit the NAMS website and get themselves updated. Now, with these few words, I'll stop. Again, welcome all of you to this important session, which would be coordinated by Professor Kharbanda, and one of the most eminent dental sciences scientists in the country. And we are privileged to have him as a chief coordinator. Over to you, Dr. Jaswant.
Thank you, sir. So now I request the technical team for the message from Professor Digambar Behera. Sir is the president of National Academy of Medical Sciences.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and you will like them and found them useful in your future lives. Thank you.
Thank you, sir. Now I request for a message from Professor M. Srinivas. Sir is the Director of All India Institute of Medical Sciences, New Delhi.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you. Now it's time again to briefly introduce the chief coordinator for this series, Professor O.P. Kharbanda sir. He is currently serving as director at Delhi Cleft Care Center and also is Professor Emeritus and Council member at our National Academy of Medical Sciences. Sir has formerly served at All India Institute of Medical Sciences, New Delhi as chief of Center for Dental Education and Research and also founder chief for National Referral and Research Dental Institute, also chief for KLV Center for Medical Education, Technology and Innovation. So just with brief introduction, as we all know, sir, and without taking much time, I request, sir, for his remarks on the on today's topic, since it is very important, as sir emphasized on it in the beginning itself. So, sir, over to you for your pearls of wisdom. Thanks.
Thank you, Dr. Daswant, for the kind words and the introduction. Let me see if I can come up to the expectations, which I'm trying my best. I like to thank the National Academy of Medical Sciences, Dr. Umesh, Dr. Sood, and Dr. Daswant, and everyone for having considered our request to include dental and oral health series among the all medical topics. So this was kind of a missing link in the medicine and dentistry. And by holding this series, we are trying to link both the healthcare professionals from dental and the medical domains. Within dental domains, since it is a very large field, we chose about 10 topics which were absolutely relevant and often understated on the medical side. Also, the idea was to choose speakers who are very high in their domains, so that they can even give an updated information to our dental faculty and dental students. At this outset, I would say the response has been very encouraging, and today even I can see that we have deans from Odisha, from Manipal, and very senior people who are attending this themselves. So I like to thank Dr. Uh, Dr. Bhuya and Dr. Mitra Hegde for being available themselves beside, of course, their students. Dr. Deepika is worked with me when she joined with me as a young faculty member, and she has been groomed and has shown the great potential to expand this field of oral cancer prevention, and more so with related to the AI. And and that is the reason I approached her, and she accepted the request. Now, why we need AI and teledentistry in oral cancer is that quite often because I was also involved in the National Cancer Program, where we put oral cancer as one of the priority areas for national screening. The hiccups are the availability of expert at the remote site. And I think Dr. Deepika is going to discuss all these issues. And this is also an area of priority by the WHO, because now they talk a lot about amoral health. Because when we represented that India is connected with mobile phones so nicely that even if people don't have a drinking water, safe water, but they have the telephone connection. So that is the beauty of mobile phone impact technology or teledentistry or telemedicine. So without taking much more time, I will request the Dr. Dr. Kapil to please take it forward.
Thank you, sir. So now it's our time to know, and my time to introduce today's speaker, Dr. Deepika Mishra. Ma'am is professor at Department of Oral Pathology and Microbiology at Center of Dental Education and Research at AIIMS New Delhi. In accordance to the topic, ma'am is having a deep interest in diagnostics in oral cancer and oral potentially malignant disorders, and also artificial intelligence in oral and maxillofacial pathology. So, ma'am has numerous awards in her name. Along with ma'am has also worked with IIT Delhi to develop detection devices for screening. Also, ma'am has trained the ground level workers, staffs for better utilization of the services. And ma'am has numerous publications in international and national journals and book chapters. So with a brief introduction, now I would like to hand over the dais to today's speaker, Dr. Deepika Mishra, ma'am. Ma'am, over to you. And all are eager to hear you, ma'am.
Thank you so much for your kind words, and special thanks to Karbanda sir for giving me this great opportunity, as well as all the NAMS dignitaries and all the seniors. It's been my privilege to share and share my journey, as well as also take you through this journey of early diagnostics. Just one second. Early diagnostics in oral cancer. And I'll just put it on the share. So, respected President, office bearers of names, also, I also acknowledge and respect the messages which we have received from our Director AIIMS. Also, I'm very, I'm really fortunate, full of gratitude, seeing so many teachers and colleagues and also postgraduate students as also the audience here. So it is an honor to speak today on this particular topic that sits at the intersection of pathology, public health, digital health, as well as AI, early diagnostics in oral mucosal precancerous lesions. So despite the fact that the oral cavity is one of the most accessible sites for clinical examination, a large number of patients we have seen, even at AIIMS, they present still late, especially at third or fourth stage of oral cancer. And Kharbanda sir always emphasized when I joined here that why do they present so late? So is there what are the real challenges? So the real challenge is not only recognizing a lesion, but recognizing the right lesion early in the right place, and then ensuring timely referral. So my presentation today will also focus on how teledentistry and AI can help us improve from opportunistic detection to systematic early diagnosis. And before I begin my topic, I just wanted to take you through a small story. So in oral pathology, the tragedy is often not that the lesion was invisible. The tragedy is that it was visible but not acted upon in time. So a small leukoplakic lesion, which might be just a white patch, may look harmless, but it may be painless also. So it may be dismissed by the patient or even underestimated at the first contact where he first approaches nearby areas. But somewhere between first appearance and the specialist diagnosis, the window for early intervention narrows. So today's talk is about how we can reduce that gap between first visibility and correct action using teledentistry, digital imaging, and AI. So that's why this particular technology has become very, very important, especially as far as oral potentially malignant disorders or diagnosing oral cancers at an early stage is concerned. So just before we begin, I just wanted to briefly introduce what are these oral potentially malignant disorders. So they were initially termed as precancers in 1805. So they are basically defined as lesions that may progress to invasive malignancy. In 1978, there was terms like precancerous lesions, precancerous conditions. So we may come across these terms. So there was some sort of distinction which was made. But in 2005, WHO held a workshop wherein they unified terminology as oral potentially malignant disorders to cover all clinical presentations with oral cancer risk. So as we understand from this name, oral potentially malignant disorders, it means there's a list of entities which can have various different potential of turning into malignancy. So the global prevalence is somewhere close, approximately 1 to 5%. Again, these are different entities, so they can have a different prevalence rates. And why this is more important in Indian context is because in India, one of the survey has actually found that 80% of oral cancers are actually preceded by oral potentially malignant disorders. So if we can identify them, we can actually stop from converting into malignancy for majority of such cases. Most common ones which we have already heard of are like leukoplakia, white patch, or red patch like erythroplakias, oral submucous fibrosis where we see that the patient's mouth opening keeps on reducing, mostly associated with frequent erica nut or betel quid users. Then oral lichen planus is again most autoimmune disease, mostly seen in females associated with stress. But now in this recent WHO 2022, they also have now introduced oral lichenoid lesion in OPMDs, which looks like oral lichen planus clinically or histologically, but they can be associated with any restorative material, for example, metallic restorations like amalgams or crowns, which could be placed in the oral cavity and can lead to oral lichenoid lesion. Apart from that, there's a newer entity which is now introduced as HPV-associated dysplasia. Though in Indian scenarios, we are seeing very less HPV-associated dysplasia for last 11 years. I would say we have just reported one HPV-associated dysplasia.
Sorry, the slides are not moving, I think.
So I'm on second slide.
Can you please make it full screen?
Is it not full
It's
screen?
also not full screen, Deepika. If you could go to the full screen mode. Yeah.
Yeah, ma'am. Slideshow, please. Yeah.
But it is
Slide
not a
show.
Make it
Yeah, ma'am.
slideshow.
Please click.
Is it now full screen?
No, you need to click here, ma'am. The left click.
Just on the
slideshow.
top right hand side. Just maximize it.
Yes.
Slideshow. Yes, ma'am. Slideshow. Yeah.
So is it a slideshow now?
Just click on that.
Yeah, I've
No,
already
please.
clicked. No, okay. Still it is not? Is it
Click on the arrow. Small
Just
arrow.
just click on the arrows,
the downward arrow, ma'am.
down arrow.
Near
That
slideshow.
slideshow, there is a small button showing a small arrow downward. If you click that,
yeah, I've actually made it a slideshow. Is it still not a slideshow? Okay.
Download करो.
दीपिका स्लाइड शो है ना, उसके साथ एक एरो है, छोटा सा बटन, उसको
हाँ,
क्लिक करो जरा ऊपर टॉप में, टॉप
आप डाउनलोड करके चला लीजिए, आप जो कह रहे हैं इसमें.
that's what I was thinking. I'll just
you click that.
yes, sir. I'm just
आप कंट्रोल F5 करेंगे तो हो जाएगा. कमांड F5.
हाँ, वो वैसे मेरी साइड से स्लाइड शो ही दिखा रहा है.
कि हमारे एंड पे मेरी मैंने
Are you able to see my screen?
Yeah, ma'am.
And now?
Now.
Better.
Yes.
Done.
Yeah, it's done.
Yeah, now it's better, ma'am.
हो गया.
Yeah. Thank you, ma'am.
I'm sorry for this.
And
So HPV dysplasia is another entity which is now seen mostly in Western population and less of in Indian context. Again, introduced by human papilloma virus. So these are the other entities which we need to identify. So starting from what exactly are very routinely being done, and then what are the non-invasive techniques which are being used for diagnosing oral precancerous lesions. So the conventional way still remains the oral visual examination, which is the which has maximum, which is most cost effective and has got maximum sensitivity as well. But still, there are certain non-invasive diagnostic adjuncts which are being used. To name a few, like toluidine blue or fluorescence dye, which are like vital stainings, or oral brush biopsies, through which we collect the cytology sample and then we see it under the microscope. So among all the diagnostic adjuncts, cytology or the brush biopsy is considered to be one of the best diagnostic adjuncts as far as all these diagnostic adjuncts are compared through a Cochrane review. Of course, the biopsy, excisional or incisional biopsy, still remains the gold standard. So the newer techniques which are being now used are optical biopsies, for example, tissue fluorescence spectroscopy, Raman spectroscopy. So these are different optical techniques. Now we also read there is some sort of research also going on confocal reflectance microscopy, wherein even at AIIMS we are in that process of starting the same. Apart from that, there are other light-based detection systems like Visilight or chemiluminescence or fluorescence imaging. And coming to the other diagnostic modalities like biomarkers, narrowband imaging, these are the other diagnostic techniques or the diagnostic adjuncts, to be more precise, which are being used predominantly in the research mode. Coming to the AI-based, because when we talk about those diagnostic techniques, we also have now many of those techniques which incorporate some of the AI within their systems. So just to give you a brief idea what exactly is AI, So artificial intelligence, it's like an intelligent machines which can solve problems, make or suggest decisions, and perform tasks that has that have traditionally required humans to solve. So it's basically trying to make like an assistant. It is trying to make our things easy. Now, coming to machine learning is a subset of AI. We commonly keep using AI, but actually what we are practicing is machine learning. It's a subset wherein we are using algorithms which learn without being explicitly programmed with rules. We use data, which we say that we should use a quality data to get a quality output. So we use data to learn and match the patterns, which are basically the outputs which we require. And then deep learning or neural networks, that is again a subset of machine learning, which uses deep neural networks effective at a variety of tasks. For example, image classifications, for example, what we want to label it as low risk, high risk. So based on whatever images we collect from clinical lesions. Or it could be a speech recognition, which is, or it could be like some other neural networks which we use for different tasks. For example, language processing, natural language processing, NLPs we keep hearing. So it's like it works on the voice mode, speech recognition, and then it builds up certain models based on it. Coming to what exactly is teledentistry. So teledentistry is, it encompasses all of those things which we have just finished seeing. For example, we just heard about how oral potentially malignant disorders or oral cancers can be diagnosed clinically, as well as correlating them with certain pathology diagnosis, as well as there is certain diagnostic adjuncts which can also come into play. For example, using some optical techniques or toluidine blue. So they are also generating some sort of data sets. Now, if we have a platform which can incorporate all this particular data sets, starting from clinical images, then the histology images, also the diagnostic adjuncts, whatever data they are generating, for example, the biomarker tests, and then the clinical, the history of the patient or the demographic details, which we call them as metadata. So whatever is the habit history, the demographics, socio-demographic details, high-risk habits, so all those comes into metadata. So when we talk about teledentistry, it involves real-time synchronous. Synchronous is like live video consultations on immediate assessment and then the advice being given by the doctors. Or it could be a store and forward, which is asynchronous. For example, capture image videos sent to a specialist who would diagnose these potentially malignant disorders, do certain treatment plannings. And also they could be used, this asynchronous data can be used for second opinions, which can be taken from globally, and they are very relevant for diagnosing these OPMDs. Apart from that, teledentistry also involves remote monitoring. For example, there could be wearable devices which can track lesion progression, monitor mouth opening, detects bruxism, and ensures oral hygiene adherence. Then we also, this teledentistry also involves mobile health, M-health, which could be smartphone-based image capture. So we do understand that this is like an on-the-edge device. For example, smartphones are something which are accessible even remotely, even in remote areas where the doctors cannot reach. So if the smartphone-based capture can be, the healthcare workers can be trained on this particular modality, they can help also in proper triage of the patients. So AI is not going to replace anytime the doctors, but definitely I would say the AI compatible doctors might replace the AI not compatible doctors, for example. So that would, because that would also sort of enhance their performance, can help in their help there as a tool for them for upskilling, as well as for sort of doing some sort of redundant task for them. Also upskilling the healthcare workers where the doctors are not available, in terms of not diagnosing, but in terms of helping them triage those patients in the right direction. So this is a routine workflow which has been also given by one of the review, which mostly is being followed in teledentistry. So patient registrations with symptoms inputs is being entered, and AI can help in pre-screening, followed by image and data upload. Now, this is a very important step because the kind of data you would upload, the kind of algorithms or the models we are going to build. So this will also help in AI-assisted diagnosis. This particular diagnosis, we always require a human in the loop, which is like a remote dentist can help in consulting, using all this particular platform to give a diagnosis. And then following it, the AI can also help in giving a treatment plan, which again would be validated by the remote specialist, by the domain expert. And based on that particular output, the doctors can give a referral prescription. And also AI can also help in follow-up and monitoring. So how it could be, for example, there are certain apps which can make it automated, wherein the AI agent can get all the information from the patients regarding follow-up and can create a transcript which could be given to the surgeons or the doctors, clinicians, to sort of navigate how the patient is responding to their particular treatment. So those are all the things which are not very far off. They're already there right now, which are being seen. So just to tell you very briefly, so how these smartphone-based AI screening, they use smartphone cameras for lesion capture. There would be AI models which helps in classifying suspicious and non-suspicious lesions. It is useful in high risk and remote populations where the doctors are not accessible to help in triage. It can function even when specialists are unavailable and supports population risk stratification. There are certain teleconsultation platforms wherein this entire data is encrypted. For example, we understand there's a DPDP Act, Digital Personal Data Protection Act, which is now implemented also. Now that also ensures that we should respect patients' privacy. So all this particular data especially of the healthcare or the research data has to be encrypted. And then, which should be, again, when we are uploading it into the platform, they also need to abide with certain ABDM guidelines to upload all this encrypted data, which can include high definition video, secure image sharing, and this can reduce unnecessary referrals and enables collaborative decision making, as well as improves monitoring within public health systems. So we can have a dashboarding of the entire data. Apart from that, now there is also clinical validation and evidence. So high diagnostic agreement is being seen in in-person examination when we use these kind of platforms as well as screenings. And remote diagnosis is shown to be feasible and reliable. So there is good evidence now which is actually showing this particular result. But having said that, I would still say that till now, AI is only being used as a helping aid, and mostly we do require a human in the loop always, or a domain expert to verify whatever the AI is giving as a diagnosis or whatever results AI is producing. There has been found that two distant consultants can now perform on these teleconsultancy on this teleconsultation platforms, and that also improves the accuracy. So there's been a meta-analysis which shows high probability of detecting OPMDs remotely as high as 97% when we use these as an adjuncts. This is just to take you through some of the real-time examples which we are doing it at AIIMS in collaboration with IIT Delhi. So this is just a multimodal fluorescence imaging and spectroscopy techniques for oral cancer screening. It's a real-time approach wherein the patient, not just we are using white light imaging, but different modalities, for example, spectroscopy or fluorescence imaging. So when we use multimodal data, it definitely improves the specificity and sensitivity in detecting these oral cancer lesions. So these play very important when it's when it is to aid in from where to take a biopsy, for some dentist to sort of identify high risk lesion and to take a decision from where to take identify the lesion from where to take a biopsy, as well as whether it requires a biopsy or not. So we use them as a clinical decision support systems. And these are some of the real-time pictures how we are using this device and how we have validated it with histology and the kind of images it produces. So this is not just clinical images and fluorescence images, but also the spectroscopy. It makes it more of an objective criteria. Then these are another certain examples which are there in the literature. For example, real-time digital oral microscopy for early diagnostic purpose. So this is the confocal laser endomicroscopy, which involves real-time in vivo cellular imaging. So it's just does not use clinical images, but also without taking a biopsy, it is telling you at the cellular level what are the changes. And definitely this is again in the research mode, which is being validated. There is one group from Kansas Sloan Hospital with whom we are working very closely in this particular area to create a cost-effective confocal microscopy device, which could be used in low resource settings as well. Another very promising tool which is coming out is the fluorescence-aided intraoral camera, which does not just use one modality like white light, but also combines autofluorescence. And as we see that it also helps in increasing sensitivity and specificity and more of a dysplasia concordance. So just to sort of give a sense that when we use multimodality, definitely the results and the outcomes improves. So this is something which we are doing right now at AIIMS, which is an example of asynchronous store and forward. So we are digitizing all the clinical as well as histology image data sets, uploading it into one common platform, which is called as MIDAS platform, which is medical imaging gold standard data sets for tobacco-induced oral lesions. And we are collaborating with different institutes pan-India who are also uploading their data into AIIMS servers after agreement. So in this, we are able to do a remote interpretation. We are doing expert consultation, long-term follow-up record. We're also using it for educational purpose as well as for mass awareness. The remote the remote consultancy, especially in the outreach, is also being uploaded into this MIDAS platform. And once we upload, it is completely anonymized and can be made open access for the AI/ML experts to work and develop tools on this particular data sets, which can be validated again at AIIMS and can be used for the patients for patient care. So this is just to show how it is being done. It involves radiology, histology, as well as clinical data sets, and the entire aim is to develop a high quality benchmark data sets. So this is just to show the pipeline. We have created certain SOPs, standard operating protocols, how to collect clinical images, gross images, histology images, and whole slide scanning. And then what features to be annotated, the ontologies to be created so that the models can work on it. And then after anonymizing, giving them the coding, we upload them onto the platforms. So one of the use case scenario which came out from the MIDAS is one of the point of care screening tool, which is Arogya an app, which is developed by Indian Institute of Science, Bangalore, along with Art Park and AIIMS as a medical partner, wherein this particular app is being used by ASHAs, ANMs, and field workers to collect the metadata, for example, tobacco usage. And right now there is a telepathology or decision support system wherein the remote specialists at AIIMS, as well as different centers, they diagnose those cases and label them as suspicious, non-suspicious, and then give a clear-cut instruction to the ASHAs how to triage those patients, where to refer, whether to just quit tobacco and refer to a TCC or refer to a tertiary care for immediate biopsy. The entire data in future, we are planning to push it to an open access platform because this is the digital public good being funded by Ministry of Education. Apart from this, this helps also in dashboarding or real-time monitoring of the data, and the vision is to get it integrated into national cancer screening programs along with other cancers as well. Apart from just Arogya Arohan app, which can be used by not just ANMs or ASHA workers, can also be used by doctors for screening population for oral cancer. We are also developing a tobacco and areca nut cessation app, which is a patient support app for helping the tobacco consumers to sort of help them quit in this particular from this habit. So this is just to show you how we follow the process. We train field workers how to use these particular AI tools. We target which are outreach sites to perform the screening. And then there's a mobile interface, how we record the data, and that is how we integrate the mass screenings through these AI-enabled tools. There's just how the data is being captured in the field. It's synced to cloud. The remote specialist platform, they diagnose, they alert to the field worker, and recommendation by the expert is real time. And then we follow up those patients. This is just to show you some other examples which are there for asynchronous. Like there are certain CNN-based binary classification already being done by some of the other investigators. Though they have limited, they have performed on a very limited data sets of just 374 tongue lesions. They have found that certain models like VGD16 was found to be the most effective. And this is the, but still they have been able to sort of state that it supports early diagnosis and teledentistry screening, and it's been the cost-effective and non-invasive adjunct, though not a biopsy replacement. Similar studies has been done for squamous cell carcinoma and leukoplakia, wherein very important point was found in some of the studies wherein they have combined clinical history with image that improves accuracy rather than just the image recognition alone. So that is something which we always see it in real time with the patients, and that is a finding which we have seen even with the AI models prediction. Similarly, one of the mHealth or the mobile health device, which was tested in Australia, I would say, as well as one study was done in India as well, wherein in this mHealth study, they have found that AI-based screening was being used for low-resource community settings when used in India. Therein, in field healthcare workers, they have tested in 2,000 images, wherein they found that DenseNet 201, which is a CNN, as well as Swin Transformer Vision model, was found to have a good sensitivity and specificity. They used only white light smartphone images, and the performance dropped when there was a poor image quality control. So that is something which has been found that for any model to work better, we need to have a good quality image data sets, which again involves a good training for the healthcare workers. This is the study which was done in Malaysia using mobile mouth screening anywhere. Again, they have done on very limited data. For example, 48 adults were screened, and they found that they actually tried to close the loop, and 12 were suspicious, which were identified. Out of them, 3 were referred. And they found that mobile teledentistry was suitable for low resource settings, and it was feasible, acceptable, and effective for early detection of OPMD and cancer. So I think so. Yeah, that is something which is already has been seen till now. And what we found as a result in our particular experience with the Arogya Arohan app, when we were doing it with ISC and Art Park team, we did it in 9 different sites like Krishnagiri, Tanjavur, Kachar, and AIIMS, KLE, and different areas of Barua and Goa as well. Wherein these are the results of phase 1. Totally cases which were screened were 23,000. So when I say diagnosed, they were clinically diagnosed by remote specialists. Out of 23,000 cases, 28% were found to be suspicious. And these are the different sites, what was the proportion of suspicious and non-suspicious. So when we see Goa, where definitely it was done more in the opportunistic screening, there was very high incidence, as high as 43%. Whereas when we talk about all the other sites, the entire screening was done only in outreach sites. So even at AIIMS, it was somewhere close to 34% cases were found to be suspicious. This is just the distribution of high-risk lesions by type and site, wherein we found that 48% were non-homogeneous leukoplasias, which were again low risk compared to the ones, the high risk, for example, the erythroplasias, verrucous, and proliferative verrucous leukoplakia, as well as OSCC. So this is just a breakup, just to show that out of 24,000 cases which were screened, this is the data in 2025, and in 23,600 were diagnosed by remote specialists, and out of them, approximately 28% were found to be suspicious. We did certain AI/ML models. We used 5-fold approach, and mobile VIT, which is Visual Transformer Model version 2, which performed the best in general across experiments, and our accuracy was approximately 86% for detecting oral cancer by the AI/ML model. So as we moved further, we just involved more of our institute cohorts, different healthcare institutes, outreach sites, and we are trying to close the loop through a proper referral and treatment. What we have realized is that these tools are very important, not just for screening, but also in sort of closing the loop, so that these patients after screening are not left out. We have also involved certain NGOs like Akshapatra, and we were fortunate to screen patients at Mahakumbh in Prayagraj, wherein we screened somewhere close to 1,200 devotees there. And now we are deploying it in UP in certain districts. So we are integrating into district level NCD screening, especially in Mathura and Sambal. When we talk about this stratification of these lesions, especially in terms of oral cancer and its journey with AI, what we have realized that we not only we use these AI-based tools for risk stratification of lesions, like just showing you the journey of Arogya, our own mobile application, but also we are trying to close the loop through follow-up recommendations and empowering healthcare workers by helping them, giving these tools to take a decision, as well as alerting these healthcare workers how to try these patients and how to follow up these patients. So this entire process is being done by healthcare workers or the frontline workers. And our work, as a remote, we predominantly work as remote specialists. The doctors are working at remote specialists, as well as help in capacity building, in training them to use these AI-based tools. Just to show you, in our phase 1, out of 2,400 cases, till now we have screened 6,000 in the outreach of AIIMS itself. And out of the phase 1, 2,400 cases, approximately we helped in we are helping in, we could refer 557 cases, and out of them 134 underwent treatment. We did follow up of 234, and 37 are in the process of habit cessation. So we are following them up. This for the phase 1, we are still following up with the phase 2 cases. So we are not just leaving there, but the AI-based tools are also being now used for identifying certain biomarkers. There's a lot of genomics data which is lying there, even in the open source data sets, as well as when we do a whole exome sequencing, and we generate a lot of data sets ourselves in our labs and our departments. So we again upload that particular anonymized data, the genomics as well as proteomics data, and we use in it the models for biomarker selections, as well as which could be used for identify certain biomarkers and developing saliva-based POC kit. So this is the first POC kit which we could develop for OPMD and oral cancer screening using a single monopanel, and we are in the process of making it a multi-panel mode, wherein we are collecting more of a data. So this is one of the progress by my PhD. And these are just to show how the CNN and random forest based pilot algorithms, which could be used for proteomics data for oral cancer and OPMD. On oral cancer and OPMD studies can be used to identify certain biomarkers. So what are the challenges and future scope? So challenges still are small and heterogeneous data sets. Most of them are lying in silos. So it's a time that we move towards large multicentric AI data sets, start building upon standardized AI-based protocols. We do understand certain image quality limitations are there, and that's where the collaborations are very helpful, so that we all can improve on each other's quality standards, as well as we can understand what exactly to build up better imaging tools, what is required, and we can sort of self-improve ourselves, like a feedback mechanism by doing a routine quality checks, making these or reworking on our SOPs. So this is what we realized. We started with developing a gold standard data sets, but what we realized is that there's just a iterated process. So what we are working is like version 1 of benchmark data sets, and again, in times to come, there would be a version 2. Again, we have some of the we have certain also limited mindsets wherein we feel that can this replace the routine visual examination or clinical examination? So the answer is no, it is not going to, it cannot replace clinical examination. So we need to understand these tools are just to help us in performing better. Again, there are limited rural internet services or device access. So that's what we have realized when we were working on smartphone-based, AI-based tools. The healthcare workers were not having enough. They are not having electricity. They were not having internet. So we have to make a tool which can work on the edge in the remote areas, which is a requirement for Indian settings. So from the very beginning, we should know where we are going to use this particular tool, and that's how we should work in future in developing that tool as well. Then we need to understand there are certain regulatory and reimbursement gaps, so how we can work in those directions. Again, having said that, we need to understand that whenever we are working towards developing these data sets or these tools, there are certain ethical guidelines laid down by even WHO, as well as our national guidelines by ICMR. So we need to go through them very routinely to stay updated. And then there is a need for training and clear-cut policies, which would also, some of them are already in pipeline. So we need to be, in align with them. So those are some of the future directions wherein we all need to work to develop better imaging tools or stronger regulations and expansions. So to conclude, I would say that AI-driven teledentistry, it represents a transformative approach for OPMD and oral cancer diagnosis by integrating AI, smartphone-based imaging, teleconsultation platforms, and definitely enhances early detection and timely intervention. And that's what we have realized in our journey. It improves access to care in underserved areas where the doctors were not available. Now the healthcare workers are able to take certain decisions. And also the doctors are also now getting more employment by going into these underserved areas wherever there is a dearth. I think so now there's a lot of shift happening. Many of the engineers or the tech people are also now going to the remote areas just to understand where those tools are going to be used. It also enables remote specialist collaboration as well as tech and doctors collaboration. What we have seen, it is increasing diagnostic accuracy and efficiency, and the model holds strong potential to reduce disease burden and improve overall patient outcomes. So I would like to end with one final image in mind, that in future we should not have to wait for a lesion to become obvious, advanced, and destructive before the system responds. So a health worker should be able to capture an image, a specialist should be able to review it remotely, and an AI system should be able to flag risk, and the patient should enter the correct pathway early when the disease is still preventable, still treatable, and is still associated with hope rather than loss. So if that happens, then technology has done its real job, and not to impress us, but to help us reach the right patient at the right time. So with that, thank you so much, and I'll be happy to take any questions. So,
Thank you very much, ma'am, for the wonderful presentation and the ongoing work at AIIMS and the collaborative partners. So I again encourage the participants to utilize this opportunity and to ask questions, to clear their doubts. They can write in the chat box, or they can just raise their hand so that we can unmute and then they can ask questions. So one question, ma'am, that has been asked on the YouTube by Dr. Mohit Gupta. Ma'am, what challenges one can face during teledentistry implementation, especially in rural India?
So a very good question, actually, and that's something which we have realized. So one most important thing which we have realized is, first of all, I would say the understanding of using these AI-based technologies. So whenever we are talking about teledentistry, are the people, especially in the rural area, are they able to use those technologies? So we need to do a initial training and capacity building. We need to tell them how exactly to use these tools. Second, our tools should be so simple. They should be in their particular language. For example, they should be either in their local language. For example, when we made our Arohan app, we build up a lot of videos, because apart from just the manual, but we created a lot of videos in local languages: Hindi, English, Bengali, Tamil, whoever are going to use this particular tool. So we had to make it in the local language, very simple to understand. And the most important thing is, as a clinician or as a doctor, what we think is, whenever as a domain expert, we are building these tools, we think that we should gather as much information as possible. But when they go into the hands of healthcare workers, they don't have time. So we have to incorporate that into their daily routine, which they are doing. For example, they are just going there as a ASHA worker, or ANM is just doing certain routine screening. So if you give them an additional tool, it sort of takes on a toll that now again they have to enter this particular information. So it should be very small. So for example, when we tested our tool, it used to take just 2 minutes to enter all the information in their local language. It was asking very minimal information, whether you're using tobacco or not, or have you ever used. And then you start just take age, gender, and any habit history, and then start taking images. Again, your on the edge device should be so handy, should be able to work in an online offline mode. We should understand that not everywhere, especially in rural part of India, you will not get internet. So it should be able to work on the edge without internet. Whatever device, when we talk about any tool, especially when it has to be used in the rural part, we need to have certain clearances, for example, CDESCO clearance. So there they use AI, or AI as a software, a software as a hardware tool, wherein you need to have a AI software incorporated into some of the mobile, and then only you can apply for CDESCO clearance. So for that, you need to opt for any low cost mobile, which can be scaled up. So from the very beginning, when you're talking about teledentistry implementation in rural parts of India, you have to look for low cost, scalable solution, and which should be able to work on the edge. So I think so the most important thing is we have to take our tech partners also to those remote areas to to help them develop a tool which can work in the peripheries.
Thank you, ma'am. Another question which is posted, I'm just pasting it in the chat box, ma'am, from Dr. Tanya. So she thank you for the presentation, ma'am. And her query is that can AI replace clinical examination in oral cancer screening, maybe few years in future?
Uh, no, I do not still foresee that at all. So clinical examination still would be there. It would be a primary area. So AI can only help us assist in doing clinical examination in a more efficient manner. So of course, the clinical examination involves a lot of metadata collection, as well as not just examining but also sometimes palpating. So these technologies can help us maybe so that we are not missing out on any lesions which can sometimes miss our attention. So they can be like a diagnostic adjunct to the doctors, and they could also upskill the healthcare workers. For example, the ASHA workers or ANMs who are not very efficient in sort of triaging or identifying those lesions. So these tools can help them. So we can upskill them in proper triage or helping them in proper triage of the patients, or we can actually connect with them. But I would also at the same time, I will tell you the kind of experience what we have seen. The model which is being developed even on these 24,000 patients, which includes approximately 2 lakh of image data sets. Again, completely annotated, and with the annotation, I mean labeling of the data sets, whether it's high risk, low risk, proper triage, what it was, erythroplakia, leukoplegia by the remote specialist. So this model was working 24/7. It was learning by its mistakes. So there are ways to give a feedback to the models, and it's learning 24/7. It's not even sleeping. So it was outperforming from the remote specialist. So as of now, in sort of labeling it as high risk or low risk, it is performing better. But still, we are not able to deploy it, or we are not able to remove the human in the loop. Definitely can help as adjunct for now, but will not replace the clinical examination. So what in your
Thank you.
experience? Yeah, I
Yeah.
can.
So Dr. Priya also asked, like in your experience, so the chances of overdiagnosis of false positives in daily dentistry. So what would be its impact on the outcome that we are hoping?
So that's one of the problem areas. So, but that's how for screening we emphasize more on in high sensitivity, so that we are not missing out on any of the cases. But yes, I completely agree that would lead to false positives and slightly increasing the burden on the healthcare. And that is where we have realized that not just diagnosing or I would say screening those patients, we also need to properly triage those patients in an efficient manner. And that's why we on the parallelly we started on improving the referral system or improving the closing the loop for these screen positive patients, so that we should not just burden the healthcare nearby to that particular uh, health facility. And what we have realized is it is that's not a problem actually for now. Whoever was screened positive, it is difficult for uh, you know sort of sensitizing them to come for the biopsy. So that was the most limiting factor or most challenging thing as of now. The patients, they come for the routine screening because they are still not aware that they might have. But once they are screened positive, to get them biopsied has been the major challenge. So that is something which we have to now, which we are working on. Yeah.
Thank you, ma'am. The question posted by Dr. Nilofar that I couldn't understand it properly. Maybe, ma'am, if you could
I
have
can,
understood.
yeah, I got,
Yeah,
yeah,
please.
a good question by Nilofer. So is it possible to get clear images on the edge, and blurring of images and distorted images won't help us to give proper diagnosis of the disease? I completely agree. That's again one of the limitation when you are working with these AI tools, especially for teledentistry sort of implementation in rural part of India, wherein you are expecting that healthcare workers are going to take those images. So you will get a lot of distorted images, blurring of images. So because this training won't just sort of upskill them very quickly. The best which we have realized is we have to take a cost-effective mobile, as well as we sort of with our tech partners, we have sort of kept or sort of frozen the way the image would be taken. So the moment they focus the image, there'll be a auto switching on of the light, so that the light is somehow sort of taken care of in terms of standardization. So there'll be auto switch on of the camera lights, phone light, and then second is it auto adjusts. So we should not expect that the healthcare worker is going to take good images. So it has to be a auto mode within your tool or within the camera settings of your phone. So that is how on the edge, if you are trying to deploy these tools, these are some of the areas wherein you need to work around. And this is again a hit and trial with different, we also tried it with various phones, and we ultimately shortened it to Motorola, the lowest version, which cost around 10,000, 11,000. And then we have frozen that it would be used only for taking the images. There was one more question I saw by Rubita. How to apply for online certification course on AI in healthcare? Is the course still available? I'm not sure if it's it for me or is it for NAMS. So I can just tell you about certain online courses which are there in Coursera and Google, as well as in other platforms also, which are used for AI in healthcare. Even WHO is coming up with certain course modules for AI in healthcare, wherein AIIMS is coordinating very closely with them to develop those these course modules for medical as well as dental students, as well as paramedical students, nursing as well. And there are different online certification course being offered by now various universities, including IIIT, IIT Delhi. So these are just few of them which I know of. Yeah.
Just I would like to add here, ma'am. NAMS in collaboration with IIIT Hyderabad has started a 12-week online program. And currently the third batch is going on. It will end on 15th of March. And registration for the next batch is open. So those our PG student and young faculty members who are interested, they can just log into the website of IIIT Hyderabad or NAMS website. And we have also circulated this brochure on the chat box, so you can refer to that. You are welcome to join that. Thank you, ma'am.
Thank you, sir. Thank you, sir, for the feedback. And as all the participants, they can see the link and the brochure in the chat box. Yeah. So, ma'am, one question that I had in my mind, what all privacy-related challenges and also at times ethical challenges that you did face during dentistry. So, if there are any.
So those were the most important challenges which we actually faced even when we started with developing the Midas platform with IIC and ARPA. So initially we thought that we'll be sharing the data, and then they'll be building the models and tools for us. And it is when DPDP Act came in 2023, so which is beyond our ethical ethical clearances which we take from our institutes and clinical research agreement which we sign. So it is beyond that. So that is when we realize that the patient's privacy is the most important thing. And the data fiduciaries are always doctors, the ones who are actually collecting the data. So then we realize that the patient's data has to be completely anonymized, encrypted in the healthcare settings. And it is then we realize that we are not going to share the data. It will stay on AIIMS servers, and we build up on our own servers. And we had to develop our entire infrastructure in the form of a computational pathology lab, wherein we had to had firewalls in place so that the entire data is well protected, and only the anonymized data is something which can go and which can be which our tech people can have an access to and can build the tools, which will again be validated at the healthcare servers. So that was the most efficient way which we felt worked for the healthcare system. Second, when we were working on the edge devices, wherein the data would be collected by the outreach, again, that would have the patient's detail, the person's details and their phone numbers, which are again sensitive privacy concerns. So what we did was, it would be encrypted from the very beginning when it is getting uploaded into the servers, so that even the healthcare workers who are recording that particular data, they won't have an access of those images which they are collecting. What they'll have an access is only the name. Once they submit, the entire data is only being shared with the admin, which would be like me at AIIMS. And then what healthcare worker can only access is the name and the phone number and the recommendation. So they have to just call up the patient, and with the recommendation that you have to go to TCC, and it's a high risk. So all those privacy concerns are something which we felt that the doctors should know what are the ethical guidelines are in place when we are using these AI-based tools or these platforms. What are the checklists which we should check before uploading data into those platforms? So there are FAIR principles, there are ABDM guidelines they should be compliant to before just uploading any data into any platform, or before we start using those tools. Are they complying with Ayushman Bharat Digital Mission, or the guidelines which are important for the platforms and the tools are different, and we all need to be well versed before we start working on them.
Thank you, ma'am. Thank you for explaining it like in a very simplified manner. Sir, you were saying something. You were on mute, sir. Professor Kharbanda, sir. Your comments, please.
There are a couple of things I just wish to say, that the uses of the WHO is encouraging use of mobile phone in health education and monitoring both. And one of their successful story has been about the de-addiction, smoking cessation and de-addiction. And with respect to oral health, one of the success story which they want to do is that they want to do the surveys, population surveys on oral health condition using the mobile phone technology. And for that, the capturing of the images has to be automated, like Dr. Deepika mentioned. It is trained camera, and not only that, it is also in kind of an frame available, which we are using mainly in orthodontics now. In orthodontics, we monitor the progress of treatment by patient himself using the device, which he holds between the lips, and the camera is inserted, and camera moves by itself. So it has its own steps in recording this. So maybe Dr. Deepika can take an idea from there how that the whole device automatically works and takes picture of the palate, of the mouth, of the right cheek, left occlusion, right occlusion, all that. So the whole world is working on it actually. And India is taking a lead, particularly in oral cancer, which I congratulate Dr. Deepika for that. And thank you for sharing your experience and your research. With respect to now, there are dental clinics now which are offering a free scan, make your own diagnosis. So these dental clinics have adopted these devices in their clinic, and those who visit there, they just go, stand in front of the camera, it takes pictures and tells them you have very bad poor hygiene or you have caries. So this is being used as an education tool, screening tool, even in day-to-day clinical practice. And these devices are already commercially available, and so many clinics have installed it. Now, coming back to the oral cancer per se, here when we initiated the National Cancer Registry Program many years ago, I think it was 2018 or no, 17, I think, when the the government of India made this. So only 2 cancers were being considered: cancer of cervix and cancer of breast. Then when I insisted on adding into it oral cancer, the answer was that it will not possible, because if you do oral cancer, we have to also include males. And the argument which I that time offered was that a woman, of course, needs a male husband as well to be surviving with her if she has to be happy family. So the oral cancer was added. So out of the 3 cancers, the protocol which we produced for oral pre-malignant cancer screening was very simple, because we only said that use spatula, ice cream spatula, daylight, and ordinary gloves. So now it is the training and the keenness of examination, how it is examined, would diagnose. The reason why this becomes very critical, teledentistry or AI in oral cancer screening, is that once the frank cancer is diagnosed, even with the best efforts, even with the very high cost treatment, the life expectancy is 5 years. However, there are a certain number of cases where reversal is possible. What she mentioned in the beginning, Dr. Deepika, that reversal of becoming from pre-malignant to malignant is an opportunity which can be enhanced to great extent by telemedicine. So here the effective use of telemedicine is that, and in fact in I think Tamil Nadu, they were using this even before we are talking about telemedicine now. They were taking pictures, sending into the repository. Expert will look at that picture and suspect, no, this case needs more attention. Although the accuracy is still debatable, but even if half the patients are benefited, it is worth it. So to the audience, my request is that perhaps we have to start thinking innovative, and so that we can decrease the burden of care, because the cost of dental treatment, including oral cancer, is very high, and prevention is much simpler and possible. These were my comments for today's webinar. Yeah.
Thank you, sir.
Dr. Jaswant.
Thank you, sir. Thank you for the expert comments and the guidance. So we still we do have time, and we can take questions. If anyone want to ask question among audience, they can just raise their hand, and we can unmute them if they are hesitant to write or maybe type in the chat box. So
Just wanted to add on to what Sir
Ji, ma'am.
actually mentioned. So it was a great initiative which Sir that time took. And now among all the 3 cancers, breast, cervical as well as oral, maximum cases has been screened are for oral cancer, which was recently also published from the Parliament when they tried to evaluate the cancer screening programs. So it is the oral cancer screening which was done most widely compared to breast and cervical cancer.
Simply because of the simplified approach. Yes.
Thank you, sir.
So, ma'am, there are again praises for the presentation. People are still thanking us. And since there are no more questions, so we can now move towards the end. So now I request Professor Ajay Kumar Sood sir for the word of thanks. Sir is Deputy Secretary of National Academy of Medical Sciences. Over to you, sir. Sood sir.
Thank you, Dr. Jaswant.
I will just interrupt a little bit. I will request Dr. Sood to share the date for the next.
Yes, sure, sir. We have already circulated.
Also, the topic, it has been circulated. I will like to make it more obvious.
Yes, sir. Sir, we have already put it in the chat box, the entire brochure. But again, we will circulate and send by email also. So once again, it is my great privilege and pleasure to thank the distinguished speaker for this afternoon, Dr. Deepika Mishra, ma'am. She has covered this topic very comprehensively. It is a new area which is coming up here, artificial intelligence. In fact, the government of India is also promoting, and Professor Kharbanda has just mentioned that how this has been added to the national program for screening of the cancer. I'm sure the experiences which she has shared with all the participants, especially our PG students and young faculty member, had a lot of encouragement for that. Thank you, ma'am, for your support to the academy, and we look forward for your session in future also. I also place on record the support which we have been getting from Professor O.P. Kharbanda, sir. Sir has been our emeritus professor, senior council member, and above all, he has been an excellent teacher, and he has kindly agreed to be the chief coordinator, and he has selected, as he mentioned earlier, also the best speaker and the best topics. So thank you, sir, once again for being with us and supporting this program. I also take this opportunity to thank all the participants, especially the faculty members and PG students from dental as well as the medical colleges who have joined us. We are grateful to you for your support, and you can always come forward to take session also in future if you want to take some topic of your interest. For your information, the next session is on 20th of March, and there again we are going to discuss a very interesting topic on management of facial trauma. And one of the eminent speaker in the country, Professor Ajay Roy Chaudhary from AIIMS, CDR AIIMS, is going to take that session. So if you have any question and queries related to that topic, you can please share with us, and we will be happy to forward these questions to our distinguished speaker. Another information for our participant is that we have a ICMR, National Academy of Medical Sciences biostatistical helpline, online helpline. So those PG students who find it difficult for their data analysis, for their thesis, they can just log in and you can just put your details, and our expert from National Academy and ICMR will be happy to help you in that. We have, as I mentioned earlier, 12 weeks online program in collaboration with IIIT Hyderabad, that is on artificial intelligence for healthcare. And currently the third batch is finishing on this month, 15th of March, and the next batch registration is open. And you can refer to the brochure which we have circulated in the chat box, or you can work out the details in our National Academy website or IIIT Hyderabad website. NAMS also support CME programs by providing financial assistance to medical institution and dental institution. So those of you who want to promote CME program and require financial assistance, NAMS have funds to support that. And we have circulated the details in the chat box, or you can also refer to the NAMS website and apply us on the application form. NAMS will be happy to support you. Another information is for the PG students from northeastern state who were seeking financial support for their thesis. NAMS have a provision for that. We have circulated the details in the chat box, and also the details are available. Application forms is available on our website.
It's 4:30.
Yes, we will be happy to support you. So once again, I thank Dr. Jaswant for being with us as a moderator and supporting this program. And of course, our team from NAMS, Mr. Ravi and Mr. Shivam, who have been helping us in organizing all these on website, on Zoom, as well as on the YouTube. And they are writing to you all the details. So once again, I thank you all for being with us this afternoon and making this session very, very productive. Thank you. Over to you, Dr. Jaswant.
Thank you, sir. Thank you for the opportunity. And I think now we can conclude the session with your permission.
Thank you.
Thank you, sir.
Thank you. Thank you, everybody.
Thank you, everyone. Thank you.
Thank you, Dr. Deepika.
Thank you, sir. Thank you.
Thank you, Dr. Sood, Dr. Jaswant.
Thank you, sir. Thank you, ma'am.
And all the participants, very huge number actually. Yeah. That's very nice. And being there till at the end, that is very important.